Okay.
All right, good morning, everyone. This is the task force on accessible, affordable health care. And Representative Lippert and I will be sort of directing the meeting. Everyone is here for a robust discussion with our consultants today on some of the options that we hope to focus in on going forward. Before we begin, I'm going to turn it over briefly to Representative Lippert, and then I will add comments for some brief introductory remarks.
Right. So good morning, everyone. Because we're broadcasting as well as having participation by Zoom, I think it'd be good if we again introduced ourselves. Also let me start by acknowledging that Representative Laurie Houghton is joining us by Zoom this morning. An accommodation that that made sense for her today. So why don't we start with Laurie? Do you want to introduce yourself? And then Rich, maybe we can start at your end of the table and go around so that everyone knows who's here.
Great, thank you. So Representative Laurie Houghton, I represent Essex Junction and I serve on the House Healthcare Committee, and I appreciate you accommodating me being by Zoom today. Thank you.
And I'm Rich Westman, and I'm the senator from Lamoille County. And I serve, my morning committee is natural resources, which isn't healthcare, but appropriations in the afternoon, where we deal with a lot of healthcare funding.
Right. Senator Keisha Ram Hinsdale, Chittenden County. I serve on Senate Economic Development, Housing, and General Affairs, I think, and Senate Government Operations.
Good morning, Senator Jenny Lyons. I represent Chittenden County and I chair the Health and Welfare Committee.
And Representative Bill Lippert, representing Heinsberg, and I chair the House Healthcare Committee.
And Representative Van Donahue from Northfield, and then Vice Chair of House Healthcare.
Go ahead.
So
you want to make a couple comments, and I'll make a couple comments.
Okay. Well, so we have a lot to focus on here, but I think I want to acknowledge, and we want to acknowledge, that there's other work happening as well, parallel to the work of this task force. And I want to mention two items in particular. One is that there is a recently released healthcare workforce plan from the Agency of Human Services, I think from Ina Backus. And so I would recommend that folks take advantage of taking a look at that report. And secondly, while we also established last year a health equity process, in addition to the work that's being set in motion there has also recently been a federal grant, a substantial federal grant, I believe in the order of $28 million, that over a period of several years, that also focuses on issues of health equity. And I think it's important, again, as we look at our work, that we stay aware of the work that's happening in parallel with some of the work of our task force as well, because we don't want to duplicate work that's happening elsewhere, but we want to make sure we're coordinating and thinking carefully. And there are others as well, and I think Senator Lyons may mention some of that, but if we'll try to keep ourselves abreast of what else is happening as we look at the specific work that we're taking up here.
Thanks. And that's a really good comment, because not only is there work going on that's been directed legislatively, but there's also independent work going on for example, the Green Mountain Care Board has been looking at prescription drugs in other areas, and that does dovetail with our interests. So we'll stay connected with their work as well. We know that there's an audio only group out there working, and then not the least of which are a number of individual 501c3 organizations and advocacy groups who are very interested in the work that we're doing and are producing information for us as well as for individual legislators. So my caution to us is this: let's stay focused on the options that we will have in front of us. let's try to work together so that we come up with some comprehensive recommendations that can be followed through within committee work. And then we know that there are going to be lots of pieces of legislation, bills introduced that are going to support our work. So all of which to say, there's a lot going on. The work that we're doing, I believe, is quite critical. And I'm really excited about the next steps that we'll be taking with our consultant. So that's just a little bit, just one housekeeping. We're starting at 11. We will take a break at 1 o'clock for a lunch, and we'll return here at 1:30. And remembering that this is a room where you can bring your sandwich. Even if you're on Zoom, you can bring your sandwich to this. And so we'll all be back here. We'll take a break between 1 and 1:30. So that's all I'd like to share at this point, but thank you all for being here. And just one other comment. I did send two articles out today on diversity issues to members of the task force, and so thought you would be interested. Okay, so thank you. And we are ahead of our schedule, which is a good thing because we have a lot to cover this morning. And Joshua and Julie, thank you for being here with us. And we'll hand it over to you and help us walk through the 7 different options that we had talked about following up on.
Sure.
That's a bad sound.
So it's great to be here again. And we have Tim Hill and Beth Waldman on the phone as well. You're going to get some of Tim, Beth, and Josh show mostly for describing in more detail the 7 options that are floated up in our research and conversations with y'all. And before we get into those options themselves, I'm going to talk a little bit about the process that we've gone through to get to where we are right now. And project a little bit for what happens afterwards. And just we'll talk more towards the end of the meeting today about where you want us to go afterwards. But just from a process standpoint, I wanted to set some timing goals and identify for all of you and for everyone else that's in the stakeholder community around Vermont, sort of what we've done here before, how we got to here. And I appreciate the comments you made on the other things that are going on as we've done our stakeholder meetings as part of this to stay connected to what's going on in Vermont. We recognize that there is a lot going on. Vermont's not starting from zero. You know, this isn't a race to the finish line for any specific thing, and so we recognize that and have built that into some of our thinking as the committee members know. So I don't know if we can put the actual PowerPoint up or if it's already available for people to see that are watching.
All of the documents are posted to the committee's website. We can put them up on the screen, but either if you have them there, the easiest thing for you to do is for you to join the Zoom and I'll make you a co-host and you can share your screen. That way you can navigate around through them. Or I can do it from here, but then direct me on next slide and things like that.
Yeah, so I can try joining the Zoom, or Julie can join the Zoom, and then she
Unless
can.
the chairs don't want it on the screen, maybe they want to see the.
Yeah, that's up to
the chairs.
I think we're okay. So far, the only folks on Zoom are either consultants or task force members, and they'll feel free to speak up if they have a question of clarification or a comment to make. So
Very good.
it should be set.
Then I'll just let you know what slide I'm on when I'm speaking, and we can, if everyone has that in front of them, that's fine. So, so I'm on slide 2 right now. Just a reminder for all of us that importantly, we're looking at affordability and accessibility.
So just to be clear for those of us at the table, each of us has a printed copy of this slide deck in the papers in front of you, and it looks
Thank you.
Looks like this.
like this.
And we do want
And there are printed copies of all of the documents here on the table, for anyone in the audience that needs, they're all right here, and they're all posted to the task force website.
You know, I'm wondering, Senator, if we might not try to have it projected, because I think for those who are not on the task force or in the room, they would have to find the document, right? Whereas right now, if we project it, then it will be recorded and people can actually see what we're referring to.
Yes.
So if that's possible.
You would prefer, just say next slide when you would like me to go to the next slide. Just give me one quick second to get there. You said the PowerPoint, right, is what you're going through right now?
Yeah, we're working through the PowerPoint.
Okay.
And Julie could manage that if you wanted us to set that up that way as well.
Why don't I start doing it while Julie, you join the Zoom, and then we'll make you a co-host. How's that sound?
Okay. Any chance you could email me the link? Real quick?
Yep.
Okay. So I'm on slide 2, and just a reminder for all of us that we're looking at affordability and accessibility focused on residents and employers. So there is, as we all know in this room and in Vermont, state government, federal government, other folks for whom affordability is important as well, and that is still something that's important for this group to consider, but the prime focus is on affordability for households in Vermont and accessibility for households in Vermont. So, slide 3, the process. So at the September task force meeting, we presented a list of options without bias as the best, worst, or any such thing, just options that are occurring and that we could work on in Vermont, right? So there was a big list of things we could do. There wasn't a comprehensive list of everything we could do because healthcare is big and complicated, and there's many things going on in Vermont that we were aware of before preparing the list that we didn't include because Vermont was doing those or had done those already. And so we then took that list of options and we said, okay, let's have some stakeholder meetings. We've had 14 stakeholder meetings to date, actually a few more, I think, since this was printed. We'll continue to meet with stakeholders in Vermont throughout this process to keep us informed of the work that other work groups are doing and of the evolution of stakeholder considerations throughout the timeframe through the publication of the report. So we will continue to have those conversations so that we stay connected and are encouraged members of the committee to make sure that we have gotten the feedback that, or connected with stakeholders that we should have feedback from as part of this so that we're up to speed on the areas that are of most importance to you.
Do we have a list of those stakeholders? Do they want to remain confidential? Who spoke to equity? Like,
Yeah, we do have a list
Okay.
of the stakeholders and we're happy to share that with you.
okay, thanks.
Absolutely. As part of the work, then we took the options and we rank ordered them into top third, middle third, bottom third. And I'm gonna move to the next slide now to talk about that. Slide 4. So these are a compacted set. I forget how many variables we had, a couple dozen variables that we looked at overall, but they fell into these general 6 areas. So we looked at household affordability, and remember that we're focused on who it helps and what it helps them with. And so the number of people times how much it helps them here is sort of the way we thought about how it helps on affordability. When we get into the options here in a few minutes to talk about, you'll see that different options that we focused on help different groups of people in Vermont in different ways, right? And so when you put them all together, you help lots of people in lots of different ways. And so, it gets complicated very quickly. But when we thought about the options that in order to narrow to the top third, middle third, bottom third, we thought about how many households does it impact and how in how big a way does it impact them. And we thought about accessibility for households and how many people have more accessibility because of an option versus not having done that option, and then how big a level of change. So you could have a really big level of change for a very small group of people. That's very important. You could have a very small amount of change that's across a very large group of people. Also important, right? So those are the ways we thought about accessibility and affordability. In some cases, you have a time frame issue. So something that can't be implemented without a federal waiver and a large stakeholder process and changes in reimbursement policy. Those types of things take several years to move forward. And when we thought about time frame, and we have this on each of the slides when we start to talk about the options themselves, we also thought about time frame from not just the enactment of legislation and implementation of the program, but how long does the program have to be in place to have an outcome impact, right? And so we scored these both on how long is it going to take to get it going and how long is it going to take to see an impact. And so shorter is better from a being able to be actionable right now. The conundrum in healthcare, of course, is that longer is potentially more impactful to human lives, but it takes longer to get there. That we also looked at health equity as which options on the list could have an impact on health equity, it could have the most impact on health equity, and future questions that we'll answer on all of these include how do we measure it, right? How do we measure it? How do we do the analytics so that you have both front end where we are baseline and back end what did we accomplish information? And I think, and I just will put a plug here that we have often in Vermont implemented very forward-looking programs, and we have not as often put in place the necessary analytics on the front end, the baseline, and then in a longitudinal way, diligently over multiple years, stayed the course on reporting. And so one of the things that I think is important for us to consider in all of these is how do we put in place that baseline measurement and how do we stay the course on it so that we don't lose that baseline comparability year over year. And I know that there's, this is not a condemnation of what we've done in the past, it's just a recognition that in some cases we don't do as well at that longitudinal comparability. It makes it hard for policymakers then to decide if a program should continue to be expanded or be disbanded. So the next one is federal involvement. So again, if a waiver is necessary, if we need to engage with our federal partner, I think, or if we really don't have as much control over something like in the drug space where there's a national pricing formula at the national level would change the conversation on drugs completely, and there's little that Vermont can do to have that enacted at the national level. So that's one example of federal disengagement from where the state might want to go. On state and federal savings and costs, we can't do this, as I said, without thinking about how much is it going to cost to implement something. How much is it going to cost, and how much is the federal government going to pay? So while we're focused and purposefully focused on household accessibility and household affordability and employer accessibility and affordability, we can't leave a conversation or not think about what it's going to take to implement it. And so a program that would, let's go all the way to, we're going to pay for everybody's out-of-pocket expenses. There would be no out-of-pocket expenses in Vermont. That could be a proposal, right? That proposal would be very expensive. So a big proposal like that that's very expensive and would cost the state and the federal government quite a bit of money, might score lower than a proposal that was more targeted in our analysis, because it might be much harder in our estimation for such a proposal to get the necessary funding behind it to have it be put in place. And on that point, the art of the possible here, just remind us again that we've focused with your direction, right, on items that are possible to do. That's how we got to this rubric, and for the members of the public and stakeholders that are engaging in this, we really are focused on things that could be done sooner and be impactful to households, as opposed to things that might be very impactful but might take a long time or never be enacted. Slide 5. So here we are. I'm going to point out, this is a teaser, right? So here's the top third. These are the options that we're going to talk about for the remainder of the day. I'm not going to walk through all of these. I'm going to leave it on the screen for a moment for people to see. I am going to spend a little bit of time walking through the middle third and bottom third, because we're not going to spend time talking about those today. And so I would encourage the committee members, if you do have questions about the middle third or bottom third that you want to talk about, that we do that, now in the next half hour before we move along to really talking about the 7 that we focused on. So these options, I would also remind everyone, they're terse explanations here. They're very short, and they don't encompass all of what's behind them, of course. And so there may be some questions in that area. And also, when we were talking about some of these options, when we talk about the public option, for example, which is going to be the first one we talk about when we get into the detail, people have preconceived notions about what that might be. I would say that it's good to start there, and we'll have that conversation. What we'll find is that we have thought about these options as they would fit into Vermont's context today. And so not public option that someone wrote an article about in California, right? Because while that's informative, it doesn't fit the Vermont healthcare context exactly. And that's true for every option. My experience is that the individual state context is critical to making sure that we start that option in the right place. And so we meet the health system where it is as we move forward. And so the details really, really matter as far as getting things implemented and be done. With that, the next slide, please. So
I just have I know that when we discussed number 6, for example, one of the examples that we had asked for initial, and I will continue to ask for, so a broken record will be, if we remember what records are. Primary care for folks, and providing primary care services to get down into the bottom line, providing at least 2 visits of primary care for folks, so that it reducing out of pocket and so on. It's not listed there, but I would like to suggest that it is included in that discussion.
Yes.
Okay,
Yeah, should have been there.
thank you.
So can I just, isn't that what number 8 is, the second? But you want it moved up into the top? Or
Yeah, no, it's different. I think perhaps we had a long discussion about this in a smaller group meeting. And so I'll leave it to the consultants to explain the difference between number 8 and identifying 2 visits without out of pocket or costs.
Yeah, I think on slide 6, number 8, is a full cost sharing reduction.
Okay.
The blueprint for health option, which we'll get into this afternoon, is about expanding that blueprint accessibility through the blueprint, which could
Okay.
include some primary care supports.
I
Not
don't,
trying to.
no, I just,
Smaller option for something critically important.
yeah, I just trying to understand what the difference is between
Yeah,
what
good
that's
question.
saying.
I asked the same question.
Okay,
And I
good.
dare,
At least I got company.
and I dare say, I think many of us are very interested in strengthening primary care. And I think this is the blueprint for health piece is one of the pieces of looking at how to, one of the pieces embedded there, as I understand, is to how to strengthen the primary care work in Vermont, primary care system itself.
Yeah, and just, I won't go further, but I will just mention, because when we get there this afternoon, we may want to discuss how appropriate it is for improving our healthcare system for diverse populations.
Yeah, so we do believe, and we'll talk about this afternoon, that there's a significant potential for equity to be served by expansion of the blueprint in different ways. So because it's embedded in the community, because it's an all-payer model, there are some real opportunities there to leverage on an equity basis. So on slide 6, the middle third from our scoring, very briefly, so expanded access to primary care without cost sharing. This has been reworded a couple of times, but I think this really points towards, there was a study done several years ago on universal primary care. It has a $220 million price tag. Something scaled back from that, even eliminating all cost sharing, would still be very expensive. And so you can see it just barely didn't make it into our top because it would be very impactful. But because of that cost to get there, it slid just out of the top third for us. Episodes, episodes are in place today. Medicare is running episodes, around the country, including in Vermont. And they do have a place in the healthcare system. The question is how big of a benefit would come to households, and how much accessibility might be gained to households. And again, I think there's some to be gained in both instances, but it just slid down slightly. The community benefits reporting and charity care requirements, so that this was a hospital focused item, and we believe that, again, this is not unimportant, but there is a mechanism for having those discussions through the Green Mountain Care Board today. It's not something that necessarily requires this group to spend a lot of time on. Where a letter to GMCP from the legislature might direct it, but not in that case. Cost growth benchmarks. We are going to talk about affordability benchmarks at the state level, and we feel that the cost growth benchmark is subsumed within number 5, the affordability board, the affordability standards, cost growth attainment there. So pharmacy cost sharing limits and reductions. So Vermont's done a lot on pharmacy, a great deal. We do have the PBM regulation one, which we're going to talk about, and we think there's some things that can be done in that area. And GMCB again has a pharmacy group that's working on proposals there. I understand their final proposals won't come out till post legislative session, until next summer, maybe sometime. I'm happy to stand corrected on that timing, but I believe that's the case from my most recent conversation with Susan Barrett and her team. So that one slipped down because we do have a pharmacy one, and we think that there's a lot to be done in Vermont already. Anti-competitive pricing. any competitive contracting, we talked about this, and I think again, in the hospital realm, and that GMCB does have the right, is the right place for that to occur. And if there needs to be some shalls, which we're going to talk about in this afternoon instead of mays, then there is a place to have that conversation, and it'll be part of our affordability boards and affordability standards and cost growth containment conversation. So I don't think we'll actually lose that piece, but it is a smaller piece. And then reducing use of low value services. Ultimately, the low value services conversation also fits within the cost growth, affordability boards, and affordability standards area, and is something that we will talk about this afternoon as part of that. So on the bottom third, on page 7 or slide 7, expanding Medicaid to additional income levels for certain ages. Again, I think there is another committee that manages Medicaid and the waiver program, and that conversation probably belongs in that conversation and of jurisdiction, and certainly a straight up expansion Medicaid. We've done a great deal of expansion in Vermont, so expanding even further is just one that fell farther down. Also has a pretty significant state cost to expanding.
In your conversation with Diva, did you identify what recommendations the administration might be making relative to changes in Medicaid reimbursement and as compared with Medicare?
So we did not have information in our conversation with the administration to date on changes that would be in the budgets, in the governor's budget recommend, which I think they would, they might talk about, but they were not ready to talk about.
Right.
Yeah.
Okay. Well, and I think that members of the Appropriations Committee will be very interested in that discussion, as will all of us. So.
Right.
Yeah.
Yes. We did see, and we sat in on the hospital, the GMCB conversation yesterday with some of the analysis that was done on cost shift. I think that I'm very aware, and I think this committee's not where we'll have that conversation, but that I'm very aware of the complexities of doing that cost shift analysis, and I think that from an affordability. So I had one of our stakeholders we met with was just Holmes, and she brought up the cost shift in advance of the conversation, that presentation. And my comment to her, which I'll make here, is that when we're thinking about affordability and accessibility and how to be most impactful, quickest to Vermonters, solving the Medicaid cost shift is not a direct line to improving affordability for households. So it may over time do that. It may also have other consequences, and we could think of those as, we could think of the ability that a massive infusion of dollars on the Medicaid front might allow for us to have our workforce be in a better spot, because that money could be spent to pay exorbitant amounts that we're paying today for traveling nurses, right? We could continue to do that and essentially take those staff people from other places in the United States. I think that's a short-sighted approach, because we live within the context of healthcare systems in the United States, and I don't believe we could afford to continue such largesse, over a long period of time.
Unless there's some negotiated agreement with the federal government at some point, then that would be probably broader than what Vermont can do, but certainly having an infusion of Medicaid dollars would do all the things you were talking about. I mean, it would improve workforce and make rural healthcare more accessible, help primary care and so on, but it might be some kind of a letter we're thinking about, but I don't know.
Yeah, I do think that it's very expensive to move down that path, and it's a blunt force instrument. And we've been focused on things that were more targeted, specifically targeted, and precision instrument. So that's why I'm. Health insurance rate review clearly falls today within GMCB, and so fell down our list very quickly. Premium and cost sharing subsidies, which we have a great deal of, through the exchange, there's a great deal of premium subsidies, and I think that cost sharing subsidies, are an option. Under some of the other initiatives up above, they go hand in glove, perhaps with some of those other initiatives. Not at a broad reducing all cost sharing level, but at a targeted reducing cost sharing for specific services, for specific populations, in order to improve equity, in order to improve accessibility. And so when we get to this afternoon, we'll be able to point out some of those initiatives where those might be part of the package. Consumer focused price data, again, I think so. GMCB is working on some of that. Some of that's been done in the past. But ultimately, our internal subject matter expert conversations around publishing consumer focused price data is sure it's nice to have. We can't draw the line between that and more affordability and accessibility. Consumers aren't currently using that to drop their doctor, go to a less expensive one, that type of thing. So it is something that on the margin today is something good to do, and I think should be done, publishing the transparent data on pricing, so that in the future, when consumers are ready for it, we can make decisions based on ratings. I'll give you an example. In Maryland, they published the star ratings, and I've done some work there with one of the plans, and it has little to no impact on the selection of plan. So 5-star rating, 4-star rating, 3-star rating, consumers aren't paying attention to it, or they're not self-selecting to actively go change their plan enrollment because of it. And I think that's there's got to be a change in healthcare, the way consumers focus on healthcare. So fines for unsupported price increases. Again, that reinsurance, adjusted plan options. Just moving through these quickly here. Each one of these just doesn't do enough for enough people on the affordability front for us to have pushed it up into the top third. And the last one here is a good one. It's certainly fine to write a letter. We think it's not very most impactful thing that can happen. So it's all the way down to number 22.
Then we'll have a senator be in charge of the budget committee.
Questions from the committee? Should give a minute.
Oh.
Go ahead.
So I guess I'm wondering, with the 14 people that you interviewed that were Vermont stakeholders, how you feel like they gave you the best sense of what the federal government would be willing to partner on. Is it anything with the kind of 1332 waiver, or what was the metric for what is of interest to the federal government?
Yeah, so on the stakeholder front, I don't believe the stakeholders in Vermont are they're not where we got the federal government partnering. We have, sort of Tim Hill is our subject matter expert on the federal government and spent his career in the federal government in healthcare. And so he has had conversations with current folks making those decisions within the federal government, and that's how we judge, whether the federal government would be receptive at detail level, meaning when we talk about the options that are in the top third, at the detail level, would these find purchase with the decision makers within the Centers for Medicare and Medicaid Services and more broadly within the federal government? But generally, the requests that come from the state do end up at CMS, either on the Medicare side or the Medicaid side or both, as part of getting the financial approvals necessary.
So so you've used as you outlined earlier, a list of criteria and then a metric for scoring based upon our conversation at our previous meetings, based on your review with subject experts such as Tim Hill, federal government amenability, and the conversations with stakeholder interviews as well. And that scoring metric is how you then teased out what is now the top third that we're going to look at more in depth. And I guess as I kind of reviewing that in a way, there certainly are some things which fall into the middle or lower categories, which may have value, but don't have sufficient targeted value. So what I'm hearing you're saying in terms of impact or the cost that would come with that, or the time frame in which it could be achieved. And there may be some things that actually aren't relevant to Vermont, and they fell into the given the context that you said, the context of what Vermont is doing, has done. So there's some things which probably aren't relevant or not impactful, but it's a mix of those perhaps. And I think that because of some of the things which you've talked about, we have put some attention on in our committees previously and may still at another point in time, but they don't meet the targeted, impactful criteria that we're trying to hone in on through this task force. Is that a fair summary?
That's a spot on summary. Yes.
Yeah, there are other issues like transparency, for example, which transparent information may be critical for decision making, but it may not be something that is going to improve accessibility or affordability. It might improve decision making.
I just follow that up and just say I think the public is worried about cost and can they get a doctor?
Yeah, exactly.
And it's as simple as that. And,
To that end, I think at some point, what I'd be looking to see is, for the average family of four, this is how this would benefit them. For someone who's 55, this is what benefit them. So I think we need to really bring it down to reality for what will actually make a difference for people of these proposals.
So hopefully that'll be next step.
Okay.
Yeah.
Okay,
So
We're going to talk about that.
great.
for sure. Next meeting, we're gonna talk about that. We're gonna be doing deep dives with direction from this group in order to get to which Vermonters, which services, what are the examples that really make this real. And in a complicated fashion, an analysis of how some of the things in the top third actually fit together so that they help more people more when you do them all, or you do multiple of those options. And so, we've been doing things behind the scenes, like working on a DUA, a data use agreement with VCures so that we can actually get into that Vermont specific data. We're very close to having that data available to us, but not quite yet. We're hoping very, very soon. And that, along with other research and data, we'll be talking about throughout the day today. And I have some meetings set up next week with some population level analytics folks, some really groundbreaking IT I hope to be able to have one or more of those groundbreaking companies at one of our meetings in the next 2 months as well, is just show what they could, the art of the possible. What could we do here that you're not doing today? Again, not that we're not doing lots, but there's another level to go to as far as the population level for analysis and helping direct some of the program decisions. So slide 8. In each of the options that we're going to talk about for the remainder of the day, we identified short-term, medium-term, and long-term for sort of when could you do this stuff. And I wanted to define here for us, just so we know, when we say short-term, we mean this can happen in 6 to 12 months. Right? This is going to happen in a legislative session. July 1st, it's going to be a program, right? Like it's going to happen right away. Medium-term, longer than that. So think next after next session, right? And longer-term beyond that. I think you'll see as we talk about some of these things, there's a range depending on, all kinds of things, politics included, right? And so some of them we said, short or medium or long. And we can talk about those, and we should, right? Like, what does that mean? What are the bumps that we're anticipating to make it potentially long-term as opposed to short-term? And as we get into each one of these, I think you'll see that. I think also keep in mind that we really hope that the conversation will be robust on these options, that they'll help to float up to the top the items that are of most critical concern to each of you, and that we can we're thinking about our research questions now. So what are the questions we're going to ask the database, right? Like we're going to get in VCures, we're going to do some more state research, we're going to pull some more federal information, and we really want to get our research questions right, which means fine tuning them to what's most important to this group and what our subject matter experts believe is most impactful as far as explaining what it is it would do. And so that's really what we're listening for. And you see Julie typing, that's going to be because that's a good one. I also keeping score at home. That's a good one. We're recording that. We want to make sure we get that research question. So with that, I am gonna ask Tim to take over. You're either going to Tim, Beth, or Joshua speaking one to each option here, depending on which option we own. As far as each of the SMEs had, subject matter experts had some options that are most in their wheelhouse. And so that doesn't mean that Beth won't speak a little on public option or Josh won't, but Tim's the main player for explaining public option and leading you through that conversation. I expect there'll be some it can be complex and get pretty wonky, and so we're going to try and avoid the using lots of acronyms and federal code numbers from the federal CFR. But if we fall into any of those, please just tell us to unwonk it.
Federal CFR.
Yeah.
We're not going to use acronyms, and you used one.
Regulation.
It's an ongoing challenge.
Yeah. I step in my own bear trap all the time, yeah.
So you'll be happy to know that our legislative council once developed, I forget how many pages of acronyms. Was it, how many pages was it? It's huge.
It was many.
And extremely helpful. We need to go maybe pull that one out again. No, okay.
I think how I'm thinking about this before we say these are the 6 or 7 options that we're moving forward is I think one needs to really drastically focus on cost reduction for households. And if we find that, like, because I'm reading the public option piece and it says, this may do this, if we find that we're not getting any savings from one of those, I think we need to go
Jettison it?
look at another, like pull up another one that does. I just, that's kind of where I'm at, is I'm not ready to let go of anything until we know one of these is really gonna impact household premium and cost sharing.
So, and I guess I'm taking the point of view that these top 7 are not necessarily a given, that we're going to focus, that we may say this, based on what we know to this point, either doesn't merit what may have risen to the top 7, it doesn't merit the time, energy, and involved in the deeper dive, or yes, do a deeper dive, but we're not committing to this because in fact, it's questionable still for us as to whether it really has the impact that we're looking for.
Right.
And so that this top 7 are not a fixed list.
Fait accompli.
Yeah.
It is.
Yeah.
We are looking at the data to make an analysis and a determination of which, if any, or all, we follow through with.
Yeah.
I mean, that's where we are.
I totally agree with that, and I get the flex where we're, but I want to support the idea that whatever we do in the top 7 or
whatever
we do
Top one, right?
has to talk about cost, or we aren't answering the concern. of the
Exactly. So we want to put the little affordability, accessibility test to each one of them.
Yep, right. There are lots of good things we could be doing and working on, but we have a directive for what
Yeah.
our function is aimed at.
Good point.
Can we just pause for a moment as well? And I know that Laurie is joining us by Zoom, and I don't know if Laurie, I just kind of periodically want to make sure that if you're able to join us still by Zoom, that you're also welcome to let us know that you have something you want to chime in with or a question that you want to ask. So.
Thank you. I appreciate that. I'm not shy, so I'll chime in. I'm good right now.
Oh, hi.
All
Thank
right.
you.
Thank you.
All right, Josh, you want me to jump in here and a little overview?
So it might be helpful, Tim, if you can speak,
I go.
or we can increase the volume, the output. That'd be great. I think we're working on it.
I did want to, I knew last time there was problems hearing me. Can you guys hear me okay, or should I speak louder?
Uh-oh.
A little muffled.
It's muffled a bit.
Boy.
You were perfect last.
Yeah, last time I called in on my phone, and that's what I did this time. Let me,
Okay.
Pretty muffled.
I think we should try that because we're going to miss
It'd be hard to.
a lot.
Yeah, it's not volume, it's the
Clarity.
Clarity. Now, what do you?
He's reconnecting through his computer audio, should be better. Well, you're muted, sir. Tim, you're connected, but you're muted.
Can you hear me any better now?
Oh, yes.
Oh, beautiful.
All right, well, I'm glad the technology is consistent. Last time I was on my computer, it didn't sound good, so I called it on my phone and that didn't work. But anyway, I'm glad it sounded better. And let me just say at the outset, I think I have successfully completed my federal deprogramming training, so I will try very hard not to use acronyms, but please hold me honest to that. So public option, what we're talking about here really, following up on the conversation you just had about impact on cost to consumers. So what we're talking about here really is an insurance impact, right? A public option is creating another insurance program, another option for consumers to choose from on the marketplace or not on the marketplace that presumably would be cheaper or more cost effective for consumers. And what it really is a mechanism for the state, in this case Vermont, to leverage its position as a purchaser and a regulator to create a new option, something that the market hasn't been able to put in place to be able to give more coverage options, and in this case, insurance coverage options for state residents. I will say that typically, it's going to cost something. Typically, or I shouldn't say typically, a state could do this on their own, right? Some states have created a public option or tried to create a public option using no federal financing, no federal intervention. It was just completely a state-owned project. But as I'm talking about here, there are authorities that you can leverage under the Affordable Care Act to recapture some federal money to help you finance the public option. And we can go into that in a little more detail. So who will it affect, right? At root, what you're trying to do here is create some benefit for consumers. You want to give consumers a choice, either because there are not options available in their county or because the options they have are too expensive. You want them to have access to a benefit package, an insurance package that is affordable for them and will work for them and their families. And so in that regard, households, small employers, folks who otherwise have trouble accessing insurance are going to benefit from a public option. At the same time, right, the other stakeholders in this system, insurance companies, who will by definition have to compete with a public option or be part of a public option, depending upon how it's constructed. And I can talk about that in a little bit. Will have a stake in the game. And then providers will also have a stake in this game, right? To the extent that you want to create a program that's going to reduce premiums or reduce cost sharing, right? The primary source of savings in an insurance product are provider rates and provider contracting. And so they're going to have a stake in, if you do a public option, how that works and how that impacts on provider rates. The outcomes, as I said, that we're trying to achieve here are reducing costs. And in this case, it's cost for premium and co-insurance and out-of-pocket costs for consumers. Also increasing access, right? It can be the case, although I don't think it is the case necessarily in Vermont, where you have blank areas in states where there's not insurance products being offered. You could use a public option to fill those gaps, a public program to fill those gaps, and otherwise address market weaknesses, right? The risk pool isn't robust. There's not enough people in the plan markets. Insurance companies aren't offering enough options, right? All those things can be addressed by the public option. So let me try and walk through a little bit of the policy considerations here, right? And I'll do it kind of in reverse. The first is kind of, as I've described it, is the appetite for intervention. If you think about a public option, it can be implemented on a continuum, right? All the way on one side would be a state government saying, we are going to whole cloth create an insurance product born, operated, and run and administered by the state government, right? Think about almost a not single payer, but in that vein, a government operated health insurance program. On the other end of the spectrum, you could say the state is going to regulate insurance, regulate a public option into existence. They're going to leverage the private plans that are in existence in the state and authorize a public option and have it administered and operated by a private plan, but overseen and regulated by the state government. So you're not, the state government's not stepping in and taking over what the private sector is doing, but they're regulating it in a much more heavy way. Kind of in the middle there is, something that you could call a buy-in, right? So you have a state employees health benefit program, or you have a Medicaid program already existing in the state. A form of a public option could be, we're going to allow people to buy into those programs. We're not going to create anything new, but we're going to change the eligibility rules to such a degree that folks could get coverage and gain access by buying into these state programs. So that's kind of the first policy consideration. How far do you want to go in kind of regulating and creating this new insurance option? The second big issue is how are you going to pay for it, right? If you want to have a public option in place to reduce costs and make insurance more affordable for consumers, by definition, it's got to be cheaper or at least competitive with what's already in the marketplace, whether it's on the exchange or whether it's in off exchange. There's got to be a way to make those premiums and cost sharing and coinsurance cheaper. You could do that a number of ways, right? You could put in state money, right? You could just authorize new state appropriations through tax dollars, and state money could go in to subsidize premiums. You could conceptually, market forces, competition alone could drive prices down, right? If you create a standard benefit, if you create the public option in such a way that the private insurers are going to worry that they're going to lose market share, you could drive prices down there. That's a little more conceptual. Or, as I said, the final way you can think about this is you can negotiate on contracting and networks and price from providers, right? You can, quite frankly, reduce provider rates and limit access to providers so that you can keep the rates down. And in that way, you can reduce cost to beneficiaries. All of those things, obviously, any of those sources of funding are going to have implications that I don't need to tell you about in terms of the viability of the program and kind of what it means. So that's kind of conceptually the policy levers that are at play. Let me make that even more complex by overlaying how you might be able to leverage federal dollars to make this work, right? So under the Affordable Care Act, for states that are operating an exchange or in the marketplace, CMS has the ability to create demonstration waivers, to approve demonstration waivers that are submitted by states, right? They're called 1332 waivers. That's the section of the statute under which they fall. And so that's the title they've been given. And under those waivers, states have a lot of flexibility to waive a lot of the requirements of the Affordable Care Act, the insurance market reforms of the Affordable Care Act around accessibility, around plan benefit design, around tax credits and cost sharing subsidies. There's a lot of flexibility to waive those requirements to design a program that meets the state's needs, right? That might be more of a niche for a state to be able to meet its market needs. To date, all of those demonstration programs that have been approved by the federal government have related to reinsurance programs in states. That's by and large, almost exclusively what has been approved. But you could, you could see a world where a state would say, I want to create a public option, and I'm going to ask the federal government to approve this public option. I'm going to waive some requirements, probably around some of the insurance market rules, that you can create your own benefit package, or you can make something that works for the state. And then what you would ask the CMS to do, or what you would say to CMS and how you would leverage this public option, is you could say, you're going to reduce premiums. And by reducing premiums and cost sharing, you're going to reduce the federal expenditure for premium subsidies and cost sharing subsidies that they would otherwise pay on behalf of covered individuals in the state of Vermont. So federal spending goes down. Under the statute, you get to recapture a portion of that federal spending. It's called pass-through funding. So you've created a program that's going to save the federal government some money. The federal government is going to send some of that money back to you to finance and operate your program. Now, quite frankly, I'm sorry, go ahead.
Tim, I think we've got a question.
Yes, thank you. I want to make sure I understand that the savings is coming from us contributing revenue that reduces the cost of premium and cost sharing, or how do we achieve the savings?
Right, that gets to the financing question, right? So you gotta create premium reductions. You got to make it so this is cheaper, and you can make it so this is cheaper by reducing provider rates or putting state dollars into the program, right? And then by reducing those premiums, by reducing what people otherwise would pay, you're by definition going to decrease the federal subsidy that would otherwise go to beneficiaries in the marketplace for marketplace for the advanced premium tax credits that you get under the Affordable Care Act. So yes, you reduce the premiums, you create a scheme where you're reducing and getting more efficient. That saves money for the federal government. They're going to give you some of that money back that they otherwise would have spent. Does that make sense? I know it gets very convoluted and complicated.
And let me just jump in here to say that this would be an actuarial design that would be presented. And so it's not a spreadsheet that we come up with a few moving pieces. It's actually a pretty complex, a bunch of assumptions that go in. And the conversation here ultimately is about if the Biden administration would want to do such a program, because the way you interpret an actuarial model is that we do interpret it. There's a lot of assumptions in there, and so what we're saying by putting this into our top third is that we believe that that conversation would be a favorable one with the Biden administration, and so that the authority that exists there would allow us to create a program that would be beneficial to Vermonters today, even though the initial authority was created under a prior administration for different reasons.
Oh,
Go ahead.
after you. Go ahead.
Well, mine's partly a process question for us here today. Is our goal to try to go through in a brief way each of the 7 pieces before we break at 1 o'clock? We're saying we're going to break at 1, is that right?
Or is this the deep dive on each?
Because I have a numbers of questions, but my is we're going to come back in the afternoon perhaps and go with many more, the opportunity for more questions. So, because I have some questions as well, but we'll never get to the other pieces if we do that.
I thought we were going to do 10 or 15 in each of these and break, and then get to where we are, break for lunch, come back. And is that your understanding?
I had thought that we would do a presentation that was 10 or 15 minutes long and then have 10 or 15 minutes of conversation about each one of these. So that would be the deep dive questions. That doesn't preclude us in the last hour or so going back to some things, but I think this is the time to talk about this one in depth. And I will also say, if you look through the top ones, some of them won't have as many questions.
Yeah.
We're not going to have to spend a lot of time on. I think there's 4 of these of the 7 that we may need to spend more time on, and this one may be the most complex of all, which we purposefully put at the front, so that we would all be caffeinated and energetic and all of that for this one. So I think that, yes, this is the time to give the hard questions.
So I'm looking at some of what other states have on their front burners or their back burners. And for me, provide a rate reductions if we're I can't think about that, but I can think about Colorado, for example, financed with federal subsidies and potential pass-through funding. Now, that looks like a QHP quality health plan that's already been devised, and it says legislation stalled. Is there a federal reason for the stalling of that legislation?
No.
I mean, I think about what we tried to do with Catamount and combine NEA, BSEA, BLCT, and have all those folks together in one public option. The administration didn't like it, so it didn't go anywhere. But I'm just sort of questioning about Colorado as an example of, is that a federal government stall? Do you know, Tim?
No.
Or
And
okay.
Colorado actually has evolved, right? Just within the last week. Their legislature has kind of finalized where they want to be, and I would characterize it as more of a regulated marketplace than a public option, right? What they've ended up creating is what's called a standard benefit. They're requiring all their issuers in the state to offer a standard benefit that would then be offered to all consumers in the state. And then they've, quite frankly, regulated price reductions and told the issuers that they need to reduce their premiums via this standard benefit over the course of the next 4 years by something like 5%. And if they don't, then provider rate reductions would kick in to achieve those savings for that standard benefit. They are going to ask CMS. They've got a draft 1332 waiver request in front of CMS to use some of the pass-through funding that would come because they're going to reduce premiums in 4 years. CMS has acknowledged that it's coming. They haven't weighed in on it yet. The package, quite frankly, isn't even fully complete. So there's still a little ways to go on what's going to happen with Colorado. But it's ended up, as it got out of the legislature in Colorado, a bit more, significantly more watered down, quite frankly, than a public option as we're describing here.
Okay, thank you.
I think Ian wanted to follow up.
Go ahead, Ann.
Just, thank you, just on that specific issue, does a model like that mean by definition that it would only address the market that in Vermont is the individual market and the small business market as what it would help, which is only what, 15% of our Vermonters? Okay.
I mean, typically, right, a public option is going to be geared toward folks who are otherwise having trouble getting coverage, which is you're going to be your small group and individual market. Typically, the commercial large group market, those folks aren't going to be largely impacted by a public option because they're generally getting coverage through their employer.
So I'm just more reacting because I think probably some of our more significant underinsured are people who are, for instance, under large group plans, but they have these huge out-of-pocket expenses. So, you know, that particular group may not be our highest priority, or maybe only a subset of them that are bigger group. It's this group that where they're cost sharing because of the large group plan is a big issue. So I'm just trying to sort out which people are the ones who potentially benefit from this model.
I'm going to send a friend line out to Nolan Langwell.
Nolan Langwell, fiscal office. But I also just want to remind people that the level of financial participation or pass-through from a 1332 depends on how much federal dollars we're saving, right? And so we're not giving federal dollars to large group that are, you know, in large plans. We're getting federal dollars to folks who are in the exchange.
Yeah.
So we're thinking about 1332 and how it would help, and we're thinking about the level of federal pass-through. For those folks, we wouldn't probably have any federal pass-through. It would just have to be state dollars for those folks. I just want to just kind of remind, when we think about how much money the feds are going to give us and what for, part of that is going to be how you target the population and how much the state dollars have to go to that versus federal. So I just wanted to like that.
Thank you.
So I don't want to cut
That,
off.
I mean, that can, the only piece that, so I became confused as to there'd be eligibility requirements. You're saying that then only some people would be eligible for this public option, or if anyone elected to choose this public option instead of something that didn't work for them from their employer, we would have to subsidize that differently. That wouldn't help us.
Well, I think you just think that the amount of federal pass-through has to do with the amount of savings we achieve
From the exchange.
From the exchange is pretty much where it all comes from. So for those other folks, it would just be more dependent on how much state dollars we put in, what the provider rates are, and what services are covered by the program. Because one of the reasons Catamount Health was affordable was because it paid lower rates that were higher than Medicaid but lower than commercial. So providers don't like that. but it's cheaper for the consumer. So those are the.
Medicare level rates, who knows?
There was Medicare plus 10 or something. So those are the things you have to balance.
So, but it could, if people went to the public option, it could cost less for an employer they're not paying then for the healthcare of that person.
Yeah.
So per person, you could say, okay, if you have someone who goes to the exchange, you have to kick back a certain amount of money.
Well, I guess that gets to the point where it depends on how it's designed.
Okay.
If you design it where employers pay in or pay something, so that's how it depends on how you design it.
Okay.
And what you direct employers as having to do
Exactly.
in statute, if their employee goes to that plan.
That's why it's in May.
So can I just?
Go ahead,
from
this is a good discussion.
So, and this gets back to your question about Colorado. When I look at this list, the two further states along are Washington and Colorado.
Right.
Okay, so and just a little more information about how theirs is working and what they're doing to zero in on that might be helpful.
Yeah, I think, Tim, you were saying that Colorado has made some steps recently, so it might be helpful to be brought up to where Colorado is and then possibly what Washington State is doing.
State is further.
Right.
Yeah, theirs has been in place, it says since 19, and they're implementing.
Yeah, well, I thought they were, can you help me with this?
Yeah, so
When I read about Washington State, it talks about Medicare for all type insurance program. Is that inaccurate or accurate?
I don't know that I would I don't know if I would describe it that way. I mean, it is, it's a public option. It is not financed by 1330. There's no federal financing. It's financed entirely by the state. And it is, as I said, just to say, it's in operation now. It was authorized 2 years ago. 2021 is the first year that it's in operation. I don't have any data as I sit here on take up and kind of enrollment in terms of financing, right? It's ineffectively a rate setting scheme. They've cut provider rates and limited them to about 160% of Medicare in order to finance it. And I'm just looking here to see in terms of eligibility, it's pretty much open to everybody in terms of eligibility. But again, it's not funded by 1332 pass-through payments. So there's not the same notion of trying to target folks for the APTCs so that they can recapture savings back from the federal government.
And then the question was regarding Colorado. Maybe you could briefly repeat what you said about the.
Yeah, and Colorado had originally been talking about trying to implement a public option along the lines of what Washington has done. What they have ended up with, and the legislature just finished up over the summer, is not a public option, but what I would characterize as more of a heavily regulated marketplace. They have authorized a requirement for all their plans, all the carriers in Colorado to offer a standard option, which would be a state designed and state regulated insurance plan, insurance option, coverage option with standard benefit design, payment amounts, premium structure that would have to be offered by each carrier so that when consumers went to pick, they knew there was at least one option at each carrier that was standard so they could compare apples to apples. And then on top of that, the state has created what I would characterize as a rate reduction scheme. They're assuming that there will be premium reductions that will be associated with the standard option by creating this marketplace, by creating standardization and a competition among plans, that premiums will be reduced. But they put in a fail-safe that if they're not reduced by 5%, and I think it's over 3 years by 2024, that then provider rate reductions would go into effect for providers delivering under the standard option to achieve those premium rate reductions. They are anticipating submitting a waiver to CMS, a request to use pass-through funding to finance part of what they want to do, but it's not to finance the standard benefit. They want to use the pass-through funding to pay for coverage for undocumented individuals and to fill the family coverage gap. It's a family coverage glitch. So they're going to use their pass-through funding for something other than, stabilizing the standard benefit that they created.
Go ahead. Both of you have a question.
Well, I'm going to jump in and just say there are two questions that I have that come to mind as we're listening to this and trying to sort it out, to try to understand it, frankly, and to sort it out. One is that I'd ask you to speak to the issue, particularly around the public option. I mean, there's a continuum of what this could look like, but what kind of administrative infrastructure is would be required or has been anticipated to be required to actually implement such a program? Because I think that's important to understand as well. There's a kind of potential complexity here that interacts with an already complex system. And
right.
So I find myself thinking, how much additional complexity for what benefit and for what cost and for what sometimes the hidden cost is like, well, what would it require administratively in terms of state government or other infrastructure to actually implement something like this? And that's a major caution flag for me without knowing what.
Because that's what we discovered with the blueprint.
Well, there's different pieces of that. And so that's one question. And so let me name the two questions and then you can speak to them. And as we're talking about this, trying to where we can have the most direct impact, where we can not have to go indirectly and then indirectly to get an impact, I keep finding myself coming back to needing to understand the cost impact for Vermonters around the recent infusion of federal dollars for premiums, and which seems like a fairly direct. If we had said, and that happened subsequent to this task force actually being authorized, I think, but it's like, if we had said, well, could we put X millions of dollars into reducing premiums directly by going directly to eligible Vermonters and saying, if you do this, we will actually put significant dollars, reduce your premium cost. Now, it doesn't get to the out-of-pocket cost, but it's, as I understand it, it has substantial reductions for some Vermonters. And I personally am very interested still to know from DEVA what that impact has been, because we're in the first period of that happening and we're entering the second open enrollment where others can still join, as I understand it. Because that seems like a very direct, federal government gives money, premiums get reduced, savings are realized, costs are reduced, at least around that premium. So
If the
those are the
government
two
keeps
pieces
giving
I'd like
the
to.
money,
What's that?
if the subsidy keeps coming.
Well, if the subsidy keeps coming, but the subsidy, yes, that's absolutely the case.
Right.
It's contingent on that subsidy continuing to come, but it is here now. And I think we're foolish to not understand what that real-time impact is as we try to talk about costs.
But that goes back to Joshua's comment early on about measuring outcomes, and that we've had good programs, but we haven't always looked to see what the risk, what happens at the end, how beneficial it's been. So
But we
can we get that data? I'm looking in two different directions.
Ask the question again.
What effect have the premiums, the federal subsidies from the COVID experience, what benefit have they provided?
The additional federal premiums, as I understand it, that have been reducing premiums for Vermonters who are eligible for them.
Mhm.
I really want to know from DEVA what the impact is then, because it's potentially substantial. I think it is substantial.
Yes, you've asked, I've asked.
Yeah.
I think they're working on it. I've been told.
Who's working on it? I couldn't hear you.
Steve was working on it. I'd asked it,
Oh.
asked it. I'll follow up with them.
Yeah, because I think, again, in terms of, I mean, it is a temporary, it's not a permanently in place, but it has the potential to be.
Right.
And,
So we could demonstrate the need for putting it in place. I think that's what you're saying. So
well, and it's not
if
just,
we're writing a resolution,
Yeah,
whether, I'm not, yeah, I'm not putting eggs in the basket of the resolution,
no,
but the fact that we
Or
have
negotiation.
something happening right as we speak that is reducing costs. I want us to understand what that impact is for Vermonters right now, rather than just thinking about other complex possibilities.
we got it.
Yeah.
We got it. Representative Donahue.
just to follow up a little bit on who it helps. And my understanding is it could go beyond our little 15% individual and small group if through the mechanism of saying employers must, well, I was trying to put it into an example. So if, you know, a platinum plan currently costs $12,000 a person, but an employer who offers that is paying $6,000 of that, that what we would be doing to make it more affordable would be saying, all right, here's a public option. The public option is only going to cost $11,000 because of what we've done. Employers, you must continue to provide $6,000 of that. You can't take the savings so that your employer benefits by only having $5,000 as their share. And if I'm understanding that as the general concept of the answer you gave before, my real question is, that's not something we could do with any of the ERISA group.
Yes,
I'm assuming, and right now our large group market continues to shrink significantly because of a flight to ERISA because of requirements we're putting on the large group market.
But that's, let me ask a little addendum to your question.
Yeah.
Therefore, is if, as it Colorado, my wrong state?
Washington, so whichever one.
Carriers, yeah, Colorado has put a requirement for a standard plan on carriers. If the requirement were on the carriers, then would that mean that all ERISA or ESI plans would include that? We can't, that would not carry over to that.
No, I think it's just what the state regulates, the small group and the individual.
Yeah.
Right. It's our little tiny pie.
So
Little teeny.
I think we have at least two sort of meaty questions that are on Tim's plate right now. One is the administrative structure and the other is Don's question. So Tim, before they pile up too much, we can't keep track of them. Maybe go ahead.
So let me take the subsidy question first, right? Because there's not an immediate answer and I'm going to make it more complex. I think it's a good question and we should dig in. There has been a lot of research about what the COVID subsidies have meant nationwide. I don't know that we've seen anything Vermont specific, so we can dig into that. But the other addendum I would say is just today, as I was sitting here waiting for this to start, my feed started building up that it looks like Congress has come to a deal, or at least a tentative deal, on some sort of infrastructure package, which will presumably also include some more marketplace subsidies. So I think there's more to come, that we need to evaluate what's going to come out of this infrastructure package over the next couple of weeks, because I think there will be more to be said there. So we can take that back and do some analysis. On the administrative front, like what does it take to implement? I think that's a really good question. And as you recall, there's kind of a continuum here, right? And the continuum of options, where you end up on that is gonna really impact how complex administratively this is going to be to implement. If you think about what Washington has done, they've effectively kind of regulated their way into a public option. They've created this insurance product and then told their carriers to offer it, and they're going to regulate it through their Department of Insurance. There's obviously a lift there and more people and actuaries that they're going to need to be sure that plans are being compliant and that the program is being offered. But that is, markedly less complex and intrusive than, for example, a plan that would create a brand new insurance entity or a risk-bearing entity that is state administered with state employees taking on, or the state taking on the risk for claims and processing and paying claims would be far more complex in that world. And so where you end up is gonna depend on how complex it's gonna be. But no doubt, even on a public-private regulatory model, it's a lift, right, for a state agency, probably the Department of Insurance, to authorize and create through regulation or whatever the right vehicle would be, these new offerings, and then being sure that the marketplace was making them available and in compliance with what the state has articulated.
Go ahead.
So this is kind of a rookie question maybe, but my sense was always that Massachusetts helped pave the way through its public option for the model at the federal level. And I would imagine Massachusetts has kept iterating on that. I just felt like I would have seen them on the list, or that they still have a sort of robust public option. What's going on in Massachusetts? Because I thought
it's not really a public option in that it's a publicly financed or regulated insurance product so much as it is a publicly regulated marketplace, like, as you correctly point out, which served as a model for the Affordable Care Act. So there's not, in Massachusetts, the state is not sort of regulating or authorizing or creating any individual product or subsidizing that product. They're just telling plans what the standard benefits ought to be and how they ought to be administered under a regulatory scheme, a lot like what is offered under the Affordable Care Act, against which consumers can choose which products to offer. I will say that Massachusetts is a model for what Colorado has done on this standardized benefit, right? So they've created a standard product that every carrier has to offer, but they're not sort of subsidizing that product or sort of authorizing it as a state-run entity. It's just it's a regulatory matter to create choices for consumers against which they can pick plans that meet their needs.
So can I just directly, this idea of a standard benefit, isn't that what the Affordable Care Act created with the qualified health plans? How is what they're doing differently?
Right. It created it gets incredibly complicated quickly, but the Affordable Care Act, right, requires certain benefits to be created, and it creates metal tiers in terms of cost sharing and how rich the benefits would be. My understanding about the standard option, as it's described, is it eliminates any discretion that a carrier would have in terms of its benefit design, what it offered, how it offered it, so that by carrier, right now, even with the regulations and the requirements around metal tiers and standardized benefits, carrier to carrier, different options could be different, right? Different plans are going to be different. It could be hard sometimes to compare apples to apples always across carriers on different insurance offerings. The standard benefit just goes a level deeper in prescribing precisely the benefit design and benefit offerings such that they are directly comparable carrier by carrier.
Can I just note that Jen Carvey at one point, maybe the time has passed in the conversation to weigh in, but
we start looking deeply into requiring employers to do things around what they do and don't pay for, and offering or going toward employee healthcare. We need to look carefully at what the legal parameters are around that, because ERISA preemption is fairly broad.
That was back to, to my prior question, right?
I will will say, since you're talking about these standardized, I mean, I'm just looking on the Vermont Health Connect website and the healthcare advocate, we know more about the specifics, but I think we do have standardized plans in Vermont where you can really do that apples to apples comparison of exactly the same plans and then some non-standardized plans where the carriers can innovate more. I think you've already done some version of what Colorado is doing with that idea of a standard plan.
Other than elimination of the metal levels,
Right.
which they've done, and we still have the metal levels.
Right, we still have metal.
Yeah.
Well, obviously, we're not gonna, I don't wanna preempt the continued conversation here. I just wanna do a time check. It's 12:40. We could get through one, maybe even two more before 1 o'clock. We can continue on this one if you like. And before we moved, I would focus us on again, the who here is that small group individual market. The other ones we're gonna talk about are different who's. In many cases, some of the same who's, and the what's here is focused in that area as opposed to some of the other things we're going to talk about for the remainder of the day are focused on different who's, different what's.
I say there's a hue and cry that we go ahead to the next option. Yeah, thank you.
Tim, any last comment on this before we do?
No,
Or you
no,
good?
it's been a good conversation. Nothing from me.
Very good, thank you.
And it's so-
So the next one is the Medicaid postpartum coverage. This is one of those that is not less important. It's super important. Like extending that coverage for 12 months post-birth is the evidence on this is that it is very important to have that coverage and for it not to lapse. And to the extent that there are any percentage of individuals on your Medicaid program today that do lapse coverage in that 12 months, extending that is something that we should do. And my understanding is that, so first of all, it'll affect, somewhere between 43 and 48% of births in Vermont, depending on the year that we're measuring it. And we know that individuals do lose their coverage, on Medicaid, even, moms, that circumstances change and lapses in coverage happen, and just allowing that to be a categorical issue, which is, it doesn't matter what happens to your income in those 12 months. It doesn't matter what else is going on. You have coverage, you get coverage. We know the clinical outcomes are better. We as a society know that. We've got lots of studies on this. And so my understanding here is that Vermont currently covers that through 60 days. That doesn't mean that half the moms don't stay on the whole year anyway, right? But I don't have that information today. That's the deep dive information. And I believe that, so getting those actual numbers and DEVA, the administration is working on this, the numbers for this already, and they have the numbers, they do own the numbers on this. And so in being efficient with the use of our resources for you, we're going to depend on the administration to help put the analytics on this for us.
I do know that there's a significant support for mothers who end up with postpartum depression as a result of having this and something like this in place. And do you know if DEVA or Department of Health is collecting data about postpartum depression? There's been a lot about that recently in the literature. So just if that's happening.
Sorry, grant.
Huh? Can we get that? Yeah, okay. And Senator Westman.
Yeah, just back up. How many people lose their coverage? Repeat what you said at the beginning of this and how many people lose their coverage.
Yeah, so I don't know the answer to that question of how many people lose their coverage. My comment on it was an example without the data. So in other words, we need the data about how many people lose their coverage that are moms, very specifically that are moms. On average, the churn rate in Medicaid is around 45%, right? Like, so that's people not on for the entire year, whether they come on and go off and come on and go off. But how that average plays with moms who just had babies, I don't have that number today. That's information that we'll need to get between now and the next meeting.
So it would also be interesting to know that by racial and ethnic differences, groupings, and as well for postpartum depression, all of the data, if we, as much as, I don't know whether that's has been collected or available, but certainly something.
Yeah, I'll back up. It would be important for me to hear that, coming from someone that lives in a community with a small hospital. And we, over the last 5 years, have gone back and forth, whether or not we were going to keep births in our hospital, because most rural hospitals in this state, having a birthing center is a loss. And so we are in a tenuous situation in a number of communities across the state, whether or not the hospitals will even offer a birthing center. So if I'm losing coverage halfway through, we've been covering all of that. And if I can help make up that gap for the providers to keep the births in that community, that's an important thing for me to be able to understand how this picture all fits together. We've twice at my hospital come down and at the board level had to discuss this, and we decided as a policy, no matter how much money it lost, we were going to continue with births. But I don't think we're alone.
Or not.
Can I just make sure I understand fully that this is there a way to subsidize postpartum coverage for anyone who has insurance that might be too expensive for them to access postpartum care? Is this just if you're only Medicaid eligible, this helps you?
So this one is only Medicaid eligible. However, I did have a conversation with Blue Cross, and I asked if they could get me the information on how many individuals that have babies paid for by Blue Cross leave Blue Cross's coverage within 12 months. I expect that number to be a single-digit percentage, but I don't know that, right? Like, and so I asked for that information to answer this exact question, which is this a problem in other places that we need to solve, or is this just a Medicaid problem to solve?
Free clinic.
I mean, having just gotten married and knowing what that does to the cost of healthcare, right? As people want to make the decision to have a family, I feel like it's a bigger problem for everyone. I don't know that I'm not sure the metric about leaving coverage is a good proxy for that, if that makes sense. I think people just become severely underinsured and make tough decisions about how to access care during that period of time.
Yeah, so that's a more, the yes or no is a very straightforward measure to get. Do they have the individuals that have a baby on commercial coverage forego care for them or their child in the year post-birth is a much more challenging question. We'll take it down. It's a very hard one to get at.
Yeah, I guess even if you just asked, what does it cost the average person to do that? It just feels like that should be a question we know that we have some answers to about the cost for someone on private insurance to have a child and properly care for them, access all their.
Well, it does get to and price transparency. So my husband and I were having a discussion about this last night, so I think it's kind of neat that you brought it up. We read an article where the family first baby cost $3,000 and the second baby cost $60,000. So it depends on where the birth takes place and other getting experiences, but their insurance did not cover all of that. So, anyway. But it would seem to me, I don't know whether there are other questions. It sounds like we're just looking for data that would help us justify this, how broadly to, we could also, if Blue Cross and Blue Shield gives us information, that would be helpful. And whether or not we can mandate that kind of coverage for all carriers is another question, but something to look at. And again, it's a really important part of prevention and going upstream.
Right.
Totally.
So I would just focus us here too. It's short term to do go ahead and do the Medicaid expansion here. It's midterm to long term to identify, that it had an impact that was, had an impact on equity, had an impact on out-of-pocket costs for individuals on the commercial market. And the conversation here today, I just want to make sure I understand it correctly. You want us to look at that commercial market as well here and to see if there is something that could be done or should be done, needs to be done in that area as well.
But including, it was presumably only able to include in that the individual and small group market, not the ERISA, not all the folks, right, the regulated market only, the small pie.
Yeah.
Or small slice.
Should we try one more?
I think we can do remote access in 10 minutes. Yeah.
Oh, yeah, because we've done so much on it.
So much.
Oh, right. No, really. Seriously.
Go ahead, Sam.
Yeah, so this, hopefully, this is a fairly straightforward conversation. What we're talking about here is leveraging what I would characterize as the momentum that has occurred during the pandemic to authorize and accelerate the use of telehealth and telemedicine. Let's use the terms as broadly as we can, and keep that use up and give incentives for continuing to use those types of technologies and services as a way to promote access and particularly continuity of care for patients, right? So here, as I said, it's about preserving those gains that have already started under, in many cases, emergency authority or regulatory authority under the pandemic, either temporary expansions or kind of administrative expansions that have allowed sort of for an increased provider pool, that have changed payment and reimbursement strategies, remove barriers on treatment to allow patients to access care using technology as opposed to being face-to-face with a provider. Clearly, there's just a ton of state activity here during the pandemic. Most states changed their laws or made administrative changes to make telehealth more widely available. Some of them did that permanently, and others are continuing to think about making those permanent changes. And again, those changes are largely around reimbursement and payment, allowing providers who are either outside of the state or outside of a particular reimbursement area, and then changing restrictions on how you can actually access the service, right? Do you have to see a provider physically before you can access telehealth services, those sorts of things. This is a relatively medium time frame set of activities. My understanding is Vermont has been kind of leading here generally anyway, both administratively, and there's a number of activities going on, either authorized legislation or work groups that have come out of requirements of the legislature to kind of continue this momentum. So it feels like it's kind of on its way from a Vermont perspective, but does feel like something that we'd want to keep on the table for folks to consider.
Well, certainly the access piece and also the affordability piece jives with this. I would think.
Yeah, and as we dug into this and saw how much Vermont has done, I think the story here is not necessarily that we would recommend us doing a bunch more research here, but that we should keep in the forefront, not to stay backwards with that access expansion that we put in place, which post-COVID, it won't be this legislative session, I don't think. It would be the next one, post-COVID, where some of the federal dollars perhaps supporting some of those expansions, and some retrenchment on who can do what from where in all of this is something to pay close attention to, especially when we think about workforce. And so I think those areas are areas to pay attention to that I don't think will come to a head now, but will, as federal dollars get spent down and not replaced in future years.
I have a couple of questions about that. I know that VPQHC has worked very hard and helping to get IT equipment out to patients through their providers. And so I don't know where that stands right now. It's something maybe we could look at. And then obviously the broadband deployment is huge, but so an update on access, IT access, and for me, preferential access, and I include in that sort of the VNAs of Vermont, the long-term care facilities, and how to expand remote access through some of our other care facilities that, we think about the one-on-one doctor's appointment, but do we also think about other options going forward? I don't know what's being deliberated right now. Long-term care facilities, nursing homes, mental health facilities, substance use disorder, counseling, kids from college. I mean, we've had communications from constituents who were worried that they wouldn't be able to connect with their psychiatrist in California when they're at school in Vermont.
We have a study underway on that.
And we have that, I was just gonna say, that's part of the study that we're doing, but it would be nice to know. We want to link in with that, that's all.
This is a tangent, but I wonder if it's one that the federal government is looking into more. When I think of remote, I also think of mobile access to care and helping people with transportation barriers and places where they don't have access to certain specialties or migrant farm workers. I mean, the list goes on, and I think there's been a lot of innovation in Maine, West Virginia, places like that, that I wonder if there's additional resources and support for mobile care.
I think that certainly access to, mobile care is something that a number of places have done. And I don't know the extent to which our providers today offer any mobile services. So that is, an area that, Vermont could explore. I don't know, we haven't done any research on mobile availability of, SUD, OED via mobile, mental health services.
Mobile dental, we do have the mobile, depending on the municipality, there's some emergency response, mental health, so social workers in place. That might be slightly aside from direct healthcare, but it's not for me.
So I want to just make sure that, I don't know, again, I can't see if Laurie's with us right at the moment, but Laurie has taken a great deal of the lead in our chamber around this. And I remember she had a particular comments and questions as we went through this initially. And so Laurie, I don't know if you're there. If you are.
I'm here, thank you. And I understand not wanting to spend a lot more time on this because we are in the forefront, and I think more will just readily be available to us as some of these studies come in. I guess the thing I am most interested is what the federal government or these other states have done around the audio piece. we took a lot of testimony on that after we had allowed it through the COVID. And a study has come out recently suggesting what rates for reimbursement should be for audio only. And I'm concerned that if they aren't higher, some providers will not choose to offer audio only anymore. And that is a real access problem, I think, for a lot of people, especially in Vermont. So again, not necessarily anything I need you to do, but that is definitely a concern I have as we move forward and try and continue to allow telehealth to be a viable option for people.
And the opposite coin, right? The other side of that coin on the reimbursement, and we've seen some of this, is where there's audio only, is that inducing services that they otherwise wouldn't be providing, right? Some providers, even though it may be a reduced rate, are now charging audio only for things that otherwise may have been just a routine phone call to get an update on something. And so there's both sides of that, but we
Absolutely. Good point, Tim. Yep.
Well, and I'm going to just throw this in as well. And I think there's a consumer satisfaction metric here that needs to be understood. I'm certainly aware of some situations where it's a great deal of satisfaction because there's access that otherwise wouldn't have been possible. But I also am aware that offering telehealth as an alternative is not seen as satisfactory. And of course, we put in a provision that said you always had the right to ask for an in-person.
Right.
That's if you're told that.
Exactly, and that's the point. I think most people aren't at all aware that, and it requires a certain willingness to say, I really would like to be in person. And there's a power differential that's often there between a medical provider and a patient, or concern that you'll upset the relationship with the provider if you ask for something that they're not offering, et cetera. So, but I think there's a consumer satisfaction piece here that really needs to be tracked and understood as well, so that we're not just always assuming that it's always a positive
Experience.
experience.
That actually came up. I did give a webinar with NCSL, and that was one of the issues that we did talk about, came up. But I think that we should go to lunch. And if you believe we should come back to this briefly at 1:30, we'll do that. And then we'll move on to next options, because I think this has been really helpful.
Yeah.
It's been great.
Good.
Okay.
So
Thank you, Tim. Don't go away, and Beth, don't go away, and Laurie. We'll all be